Um, at Forlim, our core goal is the support of Australian and New Zealand veterinarians to help achieve the best possible surgical outcomes for your patients. That support is encompassed by the supply of high quality, innovative surgical solutions backed by education, training, and the knowledge that goes with them. To this end, we're delighted to have partnered with Novatech Surgical. Novatech has developed a highly specialised range of products specifically for ligament and tendon repair, and the knowledge and experience gained through that development. The aim of tonight's webinar is to share some of that knowledge. We'll look at some of the challenges we face when dealing with tendon and ligament repairs. We will look at why those challenges exist and potential solutions we can look at to help get better outcomes. So it's my pleasure to formally introduce Dr. Hélène Lepomelet, who's our speaker tonight. Hélène is an ACVS diplomat. Her experience includes work in France, Canada, and the US. She completed her residency and master's at the Ohio State University before passing her small animal board exams in 2018. She's worked as a surgical specialist in the south of France before joining Novatech's surgery team. And I'll pass over to you, Hélène. Thank you.
Thank you very much, Sebastian, for the introduction. Good evening, everyone. Welcome to this webinar. I'm really happy to be here for this webinar dedicated to Australia and around Australia tonight. So as Sebastian mentioned, we are going to talk about tendon and ligament repair, their main challenges, and how Novalig's technology can help with those challenges. So we'll start with those challenges. Tendon and ligament injuries are quite common in dogs and cats. We have acute injuries, chronic diseases, chronic injuries coming from those patients that we don't see early on after the injury, lesions coming from overuse or degenerative disease as well. They are responsible for quite debilitating conditions, like the joint luxations, Achilles tendon injuries, cranial cruciate ligament in the acute phase, but also in the long term with all the ultimate development of osteoarthritis. They all can be quite a problem for our patients. And their management can be frustrating, first because of sometimes difficulty to get full diagnostics, and then to get the appropriate treatment. We have a lot of techniques that are heavy on the patients with those transarticular external fixators. They are demanding for the client, for the patient, for the surgeon as well, increase the time in surgery and the cost as well. And there are lots of pathology where complications and failure are not uncommon. One of the challenges that comes from those tendon repair is related to the nature of the tissue we are treating. The tendons or ligaments are very organized and specific structures to respond to a need to transfer all the forces from the muscle to the bone without losing the energy and without breaking the structure itself. It is organized in a longitudinal fashion from the fiber of collagen to the fibrils, the fiber fascicles, and the tendon itself. And those longitudinal fibers are the ones that are responsible for the capacity of the tendon and ligament to sustain heavy loads, to stabilize the joint. And when we're talking about healed tendon, we know that there is an increase in the amount of small fibers after healing, and those small fibers can be less organized, going different orientations. There is an increase in the crosslinks between the fibers that will decrease the viscoelastic properties and the biomechanical properties of the tendon and ligament, which ultimately lead to a less efficient structure that can be associated with the risk of failure after surgery. It's also a tissue that is very low, very poor in cells. And those cells, the ligamentocytes, tenocytes, are cells that are very well adapted to tendon and ligament function because they have a very low metabolic activity. It's mostly anaerobic, which is really interesting when the tendon and ligament are functioning, because they are supposed to sustain long-lasting tension without a risk of ischemia or necrosis of the tissue. So this is great, but when we're talking about injuries and healing, this becomes a problem, because to heal, the tendon or ligament will need blastic cells, and those cells come from the blood supply. They are the one responsible for the synthesis of collagen. So we'll need them to get to the tendon and ligament. And for that, we know that we rely on a blood supply that can be sparse at some specific area of the tendon and ligament. There are two different systems: the intrinsic one that comes from the myotendinous junction and the osteotendinous junction, and an extrinsic one that's coming from the paratendon. So we know that in the covered tendon, this paratendon is nice because it brings direct vascularization to the tendon, allowing oxygen and nutrient to be delivered, which is not the case in the non-covered ligament and that tendon that will get the nutrition by imbibition, which is less efficient. So those non-covered will have more difficulty to heal. Those fibroblasts will come to participate to the healing, and we know that's also less intense in the patients that are older. So in older patients, it'd be more difficult to get an appropriate healing. And if we look at this nice picture here, we're in the middle of a gastrocnemius tendon, and there's a nice blood supply. And if we go closer to the enthesis, you can look at the gastrocnemius tendon here, and we can see that the vessels are actually not coming down into the gastrocnemius tendons, and it's explained part of the reason why it's really hard for those tissue to heal nicely. And specifically, the avulsions or the lesions close to the enthesis are a major problem in orthopedic surgery, because they are very difficult to heal. Most of the enthesis that breaks are the fibrocartilaginous one. And we know that when they heal, they will become more fibrous enthesis, and they have lower biomechanical properties. And those surgeries that we're facing are at a higher risk of complications or failures. So they're really more complicated to treat. One of the other challenges in the tendon and ligament repair is that we rely on sutures, and we know that despite, for example, here you can see on this table the adjunction of epitendinous suture that gets us a higher failure force to the overall suturing of the tendon. We still are, about 130, 140 Newton, which is far from what our native tendons are capable of withstanding. For example, the gastrocnemius tendon, we're about 1,000, 1,100 Newton. For the cruciate ligament, we're about 660 Newton. So those sutures need to be protected in order for them to not break too early on in the long process of the tendon and ligament to heal, and also to limit the risk of gap formation that we know decrease the ultimate force of the ligament and tendons after healing. And this immobilization that is warranted to protect the suturing can be quite invasive, and complications are not rare. As you can see on these graphs, in the early phase of tendon and ligament healing, there's almost no resistance inherent to the tendon and ligament themselves. So we really rely on our sutures. So during this period, the 3 to 6 first weeks, we really need to protect them with either full cast splint, external fixator, some half cast splint, orthosis, etc., before allowing the tendon and ligament to withstand forces from the muscle. We know that the normal tendon and ligament can approximately withstand about 25 to 33% of the 25 to 33% of the tendon strength is needed to withstand the muscle contraction forces. So we don't have to wait until the ligament is fully healed. Like you can see here, at 1 year, we get only 79% of the resistance of the tendon. So probably about around 3 months, the tendon and ligament will be able to withstand without any problem. But it needs to be protected by those external fixation. And one of the other issue with this technique, we talked about the invasive character of this fixations, the complications that are associated with, but it's also that it acts against the physiological needs of healing. The immobilization itself has a negative impact on tendon healing. As you can see in this tab here, when you fix an articulation and don't have forces going through the ligament, there is a tendency for the collagen the synthesis of collagen to slow down. There's an increase of the crosslinks between the fibers, decrease in the water and the proteoglycans that are present in the ligament and tendon, and those are really important to help the ligament function normally. And the cells, the fibroblasts, tend to be less active than if the ligament and the tendons are mobilized. So it really slows down the healing, can decrease the overall resistance of the tendon and ligament after healing. And as you can see in this graph, where they repaired a tendon in a dog, there is a group control without any injury, group with the tendon injury, and the tendon was loaded right after surgery, a group without being loaded. And you can see that the final stiffness of the tendon is closer to the normal non-injured ligament without any significant difference. So it's almost the same, while there is a significant difference between the loaded and the unloaded, and significant difference between the control and the loaded group. And it's not only on the tendon and ligament itself that it has consequences. This immobilization leads to changes in the bone, in the muscles, and in the cartilage. And those can have consequences in the short, mid, or long term for the patient. If we consider the cartilage, when you fix an articulation for a few weeks, you can already have thinning of the cartilage, you have a decrease in the quantity of synovial fluid, decrease in the oxygen and nutrient towards the cartilage. The muscle mass is probably the only one we really can see. The atrophy, you can have a decrease in the range of motion, and you have a decrease in the bone mass as well. And all that, except for the muscle, we don't really see it, but we know that it will affect clinically the patients. And if we take that into consideration when we are treating our patients, well, we probably can improve the outcome and the comfort of our patients in the short and mid-term by avoiding the consequences of this immobilization. So how can we help with the Novali technology? Well, the idea is to provide some sort of internal bracing, so kind of an external fixation, but inside, to protect the ligament repair and the tendon repair, protect the healing, and being more in favor of this, longitudinal placement of the fibers, and allow at the same time immediate mobilization under control, of course, to reduce the muscle atrophy and really improve the maturation of the collagen in the healing tendon and ligament. The other way is to replace the native structure if needed, which is the case in the hip luxation where we replace the round ligament, the CCL, collaterals if you can't fix them back. And your very chronic cases of Achilles tendon injuries where the muscle contraction will lead to a gap between the two ends of the ligament, then the tendon can be used as to bridge this gap. And thanks to the resistance of the fixation that we'll see a bit later in that presentation, we'll be able to have the dog walking on his leg right after surgery. So how do we do that? We'll see the implants first, then the biomechanical studies that we have available, and then the instrumentation kit. And then after that, we'll look at the clinical applications. So this is Novalig. That's our major implant. It's a ligament that has at its two ends leader thread that allow us to direct the ligament through bone tunnels where the ligament is going to be fixed. We have 3 different sizes, the 2000, the 4000, and the 8000. And you see those are like resistance that are way higher up than what is a native, either, for example, cruciate ligament in dogs. And this is the major implants we are using. It is made of the UHMWPE, so ultra high molecular weight polyethylene. This material is used commonly in people and in dogs already in the joint. This is the same molecules that are used for the resurfacing of all the joint replacement, different way, but it's the same molecule. And the tightrope, for example, that's already been used in the hip in dogs, and also in some cruciate repair has been used for quite a while already. There's one study that was published in the Journal of Knee Surgery in 2018 by Smith and al. That they wanted to show how biocompatible was this tissue in the joint of dogs. So they placed a piece of tightrope on the CCL. So it was not to repair, it was really in intact joints, and they would place those piece of ligament. There was one group with a piece of ligament that was intact and one with a piece of ligament that was cut, so that they could see what could be the consequences of a ligament that was worn. And they rechecked the patient 6 months later, and there was no signs on all the joints of immune responses or foreign body response in the dog's joints. So this study helped us support the fact that this material is supported in the joint of dogs. The Nova 10 is it's kind of the same that the Novalig, except that we have only one leader thread on one side, and it's a derivation to our ligament, the ligament implant, and this one is the tendon implant, specific for a fixation on one side that's going to be on the end of the tendon or the myotendinous junction. And the distal fixation that's going to be in a bone tunnel. As you can see here, the leader thread is going to be drawn into a bone tunnel with a little wire loop. And the ligament here is fixed in the proximal part of the tendon on a patellar tendon rupture. This is the third implant from Novatech Surgery, the Novalig Platin. It is our toggle implant. It has little cortical button on one end that is made of titanium for a quick fixation on the other side of the acetabular wall. This ligament goes through a bone tunnel in the femoral neck. And then there's a 90-degree return to fix this ligament into the bone with an interference screw without the need of any kind of knot. And the last implant is the extra tape. This implant was developed for extracapsular fixation stabilization of cranial cruciate ligament rupture. It can be used for other application as well. The ligament has a cortical button for a quick fixation on one end and has a straight needle on the very end to allow an easy fixation passing through the bone tunnels. And this extra tape resistance about 600 newtons, so quite close to the resistance of the cruciate ligament, for example. The fixation systems, oops, went too fast. The interference screws are the most important mode of fixations that we are using. They allow to compress the ligament against the bone in a tunnel, allowing for no metal outside at the surface of the bone, so decrease the interferences with the soft tissue and the fascia, for example. In the extracapsular fixation, for example, you don't have a big knot that you can feel and that can bother the patient. The platen in the little cortical button we introduced earlier, we do not rely on any nuts for the fixation. And in the long term, this fixation will this resistance will increase with some kind of incrustation in the bone. And we know that from cases that have been having some issues and where the implants had to be removed, especially with infection in the Achilles tendon that were done while the patient already had an infection. On the radiographs, you can see a big ovalization of the bone tunnel, and the screws are actually coming out pretty easily, but the ligament itself is most of the time really pretty hard to remove. So we have to work hard to remove a bit of the bone that cover it and then take them out. So we know we can remove them. We also know there is an inherent stability to the ligament that's at some point does not rely only on the presence of the interference screw. So we're gonna have an overlook at all the biomechanical studies that were done by the research team from Vet AgroSup with Professor Eric Viguier, that is an ECVS board certified surgeon, and Dr. Philippe Butin that did a residency and is a diploma from a French orthopedic specialization. And from Novatech Surgery, we have Dr. Bastien Gouin, that is our R&D engineer, and they work all together to do those studies. The first study that I'm going to talk to you today is a biomechanical study for the cranial cruciate ligament reconstruction. And this was done first with the 4-screw technique. So you had one screw fixing in the first bone tunnel from the origin of the cruciate and one return 90 degree, same thing in the tibia. The study was with the Novalig 8,000 Newton, and they did 100,000 cycles. That kind of is about a dog trotting for 75 kilometers in less than 48 hours. Which is exactly not what we're expecting from a patient right after surgery, but this being a cadaveric study is just going to be the results of the implants right after surgery. So what did they find? They find that no ligament broke after those 100,000 cycles. The maximum strength of the overall apparatus that you can see in the, let's see, the middle gray here is equivalent to the native ligament, which is the light gray here. So there were no statistical difference except for that one case. The initial slipping load, so when you apply the tension, there's a little slipping of the ligament. They're placed into tension. In all the cases, this initial slipping was less than 3 millimeters. And in all the cases, this load was less than what a dog, was higher, sorry, than a dog walking. It was higher in 4 out of 5 cases than a dog trotting, but it was not higher than a dog running. So this study allows to think that a dog can walk and trot right after surgery with a minimal risk of slipping, but cannot run. If we look at this curve here, so you can see it's the curves of 3 different cases. The initial slipping here is always under 3 millimeters. And with the time and this 100,000 cycling, there is no increase in this displacement, except we had actually 2 cases. So they looked back at those cases, and what they could see is that those cases had immature bone, which lead to this major displacement. So this study allows us to say that this technique is not recommended in immature bone, especially if the bone tunnels of the screws go through this immature bone, because there's really a high risk of slippage. The second study that was done by Rafael in 2020 studied the different implantation of the screws. Those screws were placed from inside out, so with a shorter length of the free ligament in the joint compared to the original technique where the screws were placed from outside in. And the result was that there's a significant increase in the maximal strength of the overall apparatus, and there's an increase in the strength recorded at 3 millimeters. So the strength necessary to do the initial displacement was way higher in this fixation on the inside out rather than outside in. So that's the technique that's now recommended. So those studies were about the fixation bone to bone. We also have 2 studies using the Achilles tendon model to see the resistance of the fixation in the bone tunnel, so the fixation distally and in the muscle. This is really important because we know with those 2,000 Newton, 8,000, 4,000 Newton ligament, those are really resistant. There's been no rupture of the ligaments in all the studies, and the weak points of the apparatus is the fixation. So Bastien Gouin and all in 2020 published this study with a separate analysis of the distal and the proximal fixation. So there's no interaction between both. And what they showed that on the proximal fixation, the mean resistance was about 682 Newton, which if you look at even the highest resistance of all the suturing techniques, we are like at least two to three times higher. And we're getting closer to the native resistance of the ligamented tendon, which is really interesting. On the distal fixation in the bone, we're about 1,000 Newton, which is close to the original resistance of the gastrocnemius tendon. So this is really interesting for our repair. The very last study, just a quick results, they changed the fixation. Originally was just simple interrupted sutures. Then we developed an overlock suture, and it's actually brought better resistance. They also used a different suture made of the ultra high molecular weight polyethylene that was way stronger than our classic polypropylene suture. So this is what we recommend now to use for this, the repair of tendons, Achilles, patellar, triceps, etc. So now moving on to the instrumentation, we have a hybrid set of instrumentation that allows you, if you get the entire instrumentation kit, then you can do all the applications. You also can decide if you want to do only Achilles tendon to get only the specific instrumentation for that application that allow you to spend less money for just what you need, but know that with everything you can do whatever you want. I'll introduce just 2 of our, I'm not going to go through all the instruments because it's going to be a little too much and a little boring, but I just wanted to talk to you about our drilling guides. We have specific drilling guides for fixation, for drilling the bone tunnels, just to make sure that we are getting our isometric point, that we are not drilling in the wrong direction, especially for the hip toggle, for example. And this is the same handle and same sleeve for all the drilling guides. And we have one tip specific for the proximal tibia for the cruciate application, a femoral guide that is made for the proximal fixation in the femur. And we have another one that's for the hip, but honestly, I think we really like the tibial one, and our surgeons really like this one for the hip application. So we'll recommend to use that one for both. The sleeve here has a depth gauge that allows you not only to know approximately the size of the screw you need, but also to double check that you're in the right position. Because if you're expecting to have a tunnel that's 20 millimeter and you're aiming for 10, then you know you're probably not in the right direction. You can replace your guide to get the best positioning you can. The other interesting instruments we have is a ratchet screwdriver that helps you keep a straight direction, and we'll see a bit later why this is really important when we're placing those large screws in our tunnels and in the compression of our ligament in the bone tunnel. So basically, when you're using the ratchet screwdriver in the in or out position, you can screw in and screw out without moving your hand from the handle of the screwdriver. So this is really nice. And we have a AO end on those screwdrivers. So you can also use other screwdrivers if you want. So let's move on to the applications of those technologies. So really hybrid system for multiple applications. Here you have a little overview of what we're going to talk about. The hip, for the traumatic hip luxation, multiple injury in the stifle, caudal cruciate ligament, tricep reinsertion, and Achilles tendon repair. Well, I'll go in a little bit more detail on a few cases. So the Achilles tendon repair using Novaten is kind of a variation of the technique developed by Morton et al. In 2015, where they started with this blind tunnel into the calcaneum. What it was working well, it was more difficult for and less repeatable for the surgeons, as it would end up sometimes in fractures of the calcaneum. And it was also very difficult to place the ligament here in a dead tunnel and get the appropriate tension. So the technique that was developed by the team, Dr. Butin and Dr. Viguier, the idea is to try to get something that was easier to do and more repeatable. So that's when they decided to do 2 tunnels that were not blind. So you can apply nicely the tension through the bone tunnels. And by having one tunnel, a 90-degree angle, and a second tunnel, you have this pulley effect that increased the resistance of the apparatus. So here is a case. Ondine, she's a 4-year-old hound dog that was presented to the clinic for a hunting injury that happened about 3 months prior to presentation. The dog had 2 private surgery that failed each time. And its surgery, this is kind of what it looked like. So you can see this massive scar tissue that is fibrous tissue that has almost no biomechanical strength. So the idea is to really remove all this useless tissue, all the scar tissue, and fix the ligament using that continuous suture in the proximal part. You got to go as high as you can in the proximal tendon, and then fix it through those bone tunnels into the calcaneum. And this is it. This is the dog a month after surgery. So compare the contralateral to this to the operated side. There's a slight, maybe a little difference, but not too bad. Good stability, no soft tissue reaction. It's really fully healed. And here is a video of Ondine at 1 month. So she just had her, so she's been three months plantigrade. She was on the spin for a month. So she has a massive muscle atrophy, but she's not plantigrade. She's putting weight on the leg, trying to run around. And this was 4 months. We did the surgery in the beginning of February, and she's still doing good, no complications. This technique is the base for all the other tendon repair. So you can treat your triceps, patellar tendon the same way. And this is really interesting also for those catastrophic cases of chronic fracture of the olecranon, tibial tuberosity, those ones that you've done like a few times that are not healing, that can allow to protect this fracture and replace the ligament in position. Traumatic hip luxation, it's really just a principle of the hip toggle, except that there's no suture or knots done. We have two tunnels that increase in theory, the resistance of the overall apparatus. And we really recommend those for the bigger patients, for the multiple injuries, because it allows the dog to put weight on really like right after surgery. You could look at that dog that had surgery the day prior to this video. Traumatic hip luxation, could not reduce it, closed, and went for this technique. And that's him one day after surgery, walking nicely on his leg. Cranial cruciate ligament using Novalig, so intra-articular replacement of the ligament with 2 interference screws in the proximal tibia and distal femur. This is the dog we saw on the radiographs, and this is 2 weeks after implantation. Dog is doing good, full weight bearing, no like maybe a lameness of 1 out of 10, 2 out of 10, but never been off leash, well restricted by the owners, and we've been about a year out, and the dog is doing great. He's back on normal activity 3 months after the surgery, full activity. This technique can be used under arthroscopy, and you can, there's actually a video that's available on our YouTube channel that you can find nicely, that was done by Yolinder's team back in Sweden. The multiple stifle injury that I started talking about earlier, I'm going to show you 2 different cases, same injuries. In this case, the surgeon decided for intra-articular replacement of the cranial and the caudal cruciates. Didn't place any external fixator, no splint, just full restriction of activity in the early 2 months. And this is the other one. Same injury, cranial, caudal, and medial collateral, but this surgeon did not want to use the intra-articular repair, so he went on using an extra-articular stabilization for the cranial cruciate ligaments and reconstruction of the medial collateral, no treatment of the caudal cruciate. I think if we look closely, there's a slight displacement that's probably related to both not repairing the caudal cruciate and maybe tightening a bit too much the lateral suture, the extra-articular stabilization, but the cat did great. So those are really, it's really helpful and nice for those multiple ligament injuries. With the help of the interference screws and also the cortical buttons, in some cases, you can repair all the ligaments with only one ligament, which is really nice. And according to our surgeons that have done them, they get a really nice stability once they place the ligament through the bone tunnels. So they really like it. We have other applications that were developed, but we don't have a lot of clinical cases or radiographs that we were allowed to show you, but those are the 3D reconstruction of medial collateral ligament in a dog, medial collateral of the corpus tarsus, and in collateral of the elbow in the complicated cases of elbow luxation that don't respond to closed reduction. So that can be useful. And there's many other applications that probably can be thought and developed for sure. I wanted to finish with talking about the complications and how to avoid them, just more to show you that even if those ligaments seems to be really interesting, they're also like any technique in surgery associated with there are a lot of complication. So implant breakage, for example, here you can see an interference screw that broke during its placement. Here, the bone that broke. In both cases, there was a mistake done during surgery. Here, the diameter of the bone tunnel in this very hard bone that is the calcaneum, and it was very hard to screw in this screw that is cannulated, and that led to breakage of the screw. Fortunately, this was a big dog and there was enough room to place a second screw. In this dog, that was early on when we did not have the small size screws, and this was actually a dachshund, so a very small dog. The tunnel was drilled a little off the middle, so it led to breakage. The surgeon knew that was going to happen, had everything ready and repaired it right away, and it healed very nicely. One of the very important points in the fixation of those ligaments into bone tunnels is the placement of the screw. Earlier, I talked to you about our ratchet screwdriver, how helpful it is to screw in straight. It's really important also, we have, everything is cannulated and we have those little blunt wires that are very useful to assess how straight we're screwing in the screw in the bone tunnel. We check that the ligament is not in the way and we screw in, and if the screw changes direction, then the guide is going to bend, and then you have to stop and change the orientation. And it's really, really important because, as you can see here, the screw that's not placed in the original straight bone tunnel goes in a different direction. First consequences is that if you're bicortical, you may break your transcortex. And the other consequences is that your ligament is crushed between the bone and the screw. And if your screw is not in the right direction, then you decrease the amount of ligament that's compressed against the bone, and you decrease the overall resistance and overall tensile of the apparatus. So it's really important to do that. Some situations a little specific, like this dog that was older and had really bad bone quality, and we had to upsize the diameter of the screw. So you can see in the femur, the screw is a little smaller than in the femur, and a second tunnel was added for security, just to be sure that it will last. It will stay in position. In this smaller patient that had a cruciate and MPL, there was not a lot of room, and the surgeon decided to go with a fixation in the tunnel, in the tibial tunnel, with the cortical button instead of putting a screw, which can be useful. Also, there's a risk of motion of the ligament in the bone tunnel, so that has to be thought thoroughly before I decide to do that. But those are options in case something goes the wrong direction. Infections, that happens. That's a worry number one. It's really important to have it because we are placing kind of a multi-filament ligament that we are not wanted to remove from the patients. So it's important to be aware, to do everything you can from the start to the end, so infection don't happen. You don't want to operate on a patient that had already an infection or an open wound. You want the owner to be aware that the dog has to be on an e-collar. They have to be rest. They should not be in the barn with the horses when they're recovering from their Achilles tendon repair. So it's really important to have those strict post-op protocols to give to the clients to make sure they understand, even before the surgery and after the surgery, that they're compliant, and that quick and perfect recovery does not exist. And it doesn't mean that it exists, but it doesn't mean that it's healed, and that they have to follow all your instruction. And one of the things I think is to really select the patient, the cases. You need to find the appropriate technique for the appropriate, what I call the patient owner couple, which means that those techniques, like all the others, are not for everybody. I think they are dogs. They are a specific pathology that won't fit for this dog. If you have an Achilles rupture with an open wound and you want to fix it right away, then I'd say go with the external fixator and what you're doing without those implants, because it's going to get infected. There's no way around. It's nice to start with the easiest cases, maybe, just to not get frustrated, because if you're starting to use those implants, everything is new. The implants, the interference screws, the kit, the thoughts are different. So there's a learning curve that you have to go through, and that also can be frustrating. So if you're starting maybe with your hyperactive obese dog, clients are crazy and this is not going to work well. So it's important, I think, to select those cases to start, like for any other technique, I think. Training is key. That's the last point. Sorry, been a little longer than expected. So we really want you to make the best out of this technology and those implants. We're trying to do as many courses and webinars as we can. So we really recommend to attend courses, because we really have seen that if, without going to a course, there is a high risk that the first case is going to be more complicated for some of us. We have upcoming courses at the ECVS in Porto in July, and we're planning on doing a course in Australia probably in next year. We don't have a date yet, but we are definitely planning on doing that. So before that, you can meet us in different courses, different meetings. ECVS in July, ACVS in October in Portland, Oregon. The ASVOT Congress is in France this year in Nice, so we will be there. And you can meet with Sebastian at the Science Week on Gold Coast next week to chat with him with those implants. Feel free also to contact us through our emails, the LinkedIn, all the social media as well. And I'd like to thank you all for your attention. And if you have any questions, I see there's a couple, we are going to answer them. And at the same time, I think you guys in a few seconds, or maybe already, you're going to have a question on your screen. And if you'd like to answer it while we are looking at the question, that would be awesome.
Thank you, Hélène. I just launched the poll. So while there is some participation, we can go through the Q&A.
Okay, so I'm going to answer to the first two questions that are kind of the same, asking about the infection rate for the implants and the experience that you guys already have with those multi-filament ligaments that are quite a high rate of infection, and what happens if they get infected. So first, yes, when you're using an implant like that, there is a risk of infection, but the risk of infection is due to the presence of the implant. So it's not the implant that is going to lead to infection, and your infection rate depends on what you do. So if you are selecting your case nicely, you are operating in very good condition with the best aseptic condition, the clients are following all the recommendations, you have a lower rate of infections. And I think the rate of infections are, in the studies there, we get rate infection for this type of surgery, but at the end, all the surgeons do not have the same rate of infection. So we don't have numbers because the infection rate depends on the techniques. If we're talking about the hip, we do not have any cases of infection reported so far. In the Achilles tendon, we have for sure. And in about, so we got a few cases back together. I don't have a published study, but more than 2/3 of the cases, we ended up finding an infection before surgery that could explain, or after, like the case I showed you the picture with all that was in the barn. He got a big wound under his splint, and it got infected afterward. So yeah, there is a risk, and I think it's really important to be aware of that. The same way when you're doing a total hip replacement, you're going to take all the precautions so it doesn't get infected, because the consequences are more important than for a simple plate and screw for a fracture. The screws are self-tapping, yes. And if you go to a course or we go deeper in the technique, we have to, they're not really tapping, they're actually going to compact the bone. So before placing the ligament and the screw to fix the ligament, we will do like a tapping. So use the screw and the screwdriver and place the screw in, screw it out, so the bone is squished to itself. And that is a technique that has been reported in people to increase the overall resistance of the ligament. We do use taps for the smaller screws, because we have 3 millimeter, 3.5, 4. Those are very small. They're also cannulated. So in the hard bone, like the calcaneum, there's a high risk of breaking the screw when you're trying to tap. So we use tap in those cases. Yes, absolutely. So in really, so there's a question, sorry, I'm reading the question, not reading it to you guys. Can you use your ligament system to support a patella repair in a large dog? I don't have in mind if we have a case like that, but this is definitely something that we've discussed and that we are hoping someone can use it. And that's definitely something that could be tried. So we do not have the study for the durability. So there's a question, sorry, I'm really bad at that. Is there any study on the durability of the fibers? Those fibers been used in people, and there are people that have had those ligaments for years, decades. They don't stretch, they don't, nothing happened to them. So the idea is that it should last the entire life of the dog. All right. So we answered all the questions that we had in the Q&A. If someone has any additional question, I'll be happy to answer them. Oh, I see that there are questions in the chat.
Yeah, there's a couple there.
Okay.
So the first question in the chat, you already answered them in the Q&A.
Yeah, and so I see a question. I'm probably going to go up, otherwise I'm not going to remove. So this is the same question. So the bone in that X-ray test with 2 screw as an open growth plates. Yes, that's exactly what I said. That's exactly the problem. Softer bones, so less resistance of the overall apparatus. This is really a problem. And one of the weakness of the fixation in a bone with interference screws is that if you have soft bone, there is a higher risk of failure, and that's why if that happens and you are worried about that in the patients, well, either the technique is not maybe the best for the patient, or you can increase the resistance by adding another bone tunnel and screw to increase the overall resistance. Oh, someone answered for me. Okay. Is there any question that I missed in the chat, or?
There's a question. Sort of, what do you see as the main benefits of an interference screw system over bone anchors, e.g. the Arthrex Secures type, still using similar suture fiber wire like a fiber?
So there are multiple things. First, over the anchors, you have a part that's coming out of the bone that can lead to some interference with the soft tissues. Usually, we also know that the suture will break at this location, while with the interference screw, that's not the case. There is no, the screws are smooth, so they are not cutting through the ligament. So using a similar suture fiber wire, and the fiber wires, fiber tech, all those sutures are not manufactured the same way than the ligament. And so they are not wired, so they are way smoother to the bone, and there is no cutting through the bone, as opposed to what we can see with this organization of the bone tunnel, for example, with the tightrope in the hip fixation.
So it's flat rather than round. Is that right?
Yes, it is flat. Yeah.
Yeah.
So someone asked, what is the advantage of excising the fibrous area of the gastrocnemius tendon rather than suturing the novatem along it as well to increase the hold on the tendon? Or does the new gap fill in with some new tendon tissue? So when you get that fibrous tissue does not have any biomechanical resistance, it doesn't do anything, and because the dog because of that, and the dog is plantigrade, you actually have a useless tendon that is actually too long. So once you cut that, and in this particular case that I showed you, we were able to bring the two ends of the ligament that was not injured together, thanks to placing the ligament and applying the tension. In some cases, you get a gap, and what we are hoping is that it will fill with some new tendon tissue. For now, for sure, we do not have like a study with either MRI or ultrasound, or had some postmortem studies, but we have cases going on that are in a year or 6 months that are out where there was a gap. What's important to keep in mind, even if we don't have the answers, is that if you have this case and do not have this option, then you're going towards an arthrolysis of the articulation, so which is far more invasive, and the post-op is quite heavy, and the function is not as good. So I think it's worth it for those cases to try that. Even if we don't have yet all the answer to make you feel super comfortable that's going to work. We've had those cases going on. We have a young husky, I think she's a year, and she was plantigrade for a few months, and we had a huge gap, and surgery I think was in October or November, and so far still doing great. I think there's another question. So no, so someone asked, so failure never happens at the bone suture interface. Didn't say that. It's actually, if you listen at the time of the biomechanical study, this is where this is the weakest point. But the bone interface with the ligament is the strongest one. So if we are talking about our Achilles tendon, actually, probably 9 out of 10 that failed on the myotendinous side, and sometimes failed on the other side. And it can fail because of a fracture. It can fail because the patient went too crazy, or because of some kind of problem either in choosing the sizes, etc. But it is the place where it felt the less for the Achilles tendon. For the CCL, this is definitely a different story. It is the resistance in the proximal tibia is not as good as in the calcaneum, and you can all understand that the bone is way softer. We are in the cancellous part of the proximal tibia is just softer bone. So this is where it fails for the CCL when it happens, and we know it. And to decrease the risk of that fail, we need to have the patients follow all the post-op recommendation. And if you follow a course for the CCL, you'll see that we have lots of things about the post-op to decrease the risk of this failure at the bone suture interface. And it's not a suture, it's a ligament, and the bone ligament interface is definitely the weakest point of the overall apparatus. It's strong, but it's less strong than the ligament itself. All right.
That's brilliant. Thank you, Helen. I can't see any more questions there. It's really fantastic. Lots of information, and you're really well presented. Yeah, thank you very much.
You're welcome. Thank you for having us today.
Yeah.
All right. Thank you everyone for coming. It was really nice to have all those interesting questions. I think those questions are fair. It's really I think it's important to to worry about things, to think about it, and to have them in mind when we are applying the techniques, because that will decrease the risk of having those complications happen.
If I may, I am just closing the poll so I can share the results. I think now you might be seeing them. So it's very split between every technique. So
Good.
almost
So
half of you want to have a lab with tendon rippers, the other half with CCL ripper, and about a third on hip luxation. So we will have to work closely with Sebastian to have
and we've done
several work.
Yeah, we just come back from London, and we actually did one course one day, and we managed to talk about everything, all the techniques. So we're less talking about the, all the theory, but more going deep into the applications. And it worked pretty well. So maybe that's what we'll do when we come to Australia. We'll do a 2-day course.
Brilliant. Thank you so much. Yeah.
Someone asked for the cadaver practice. We actually do that. Yes, absolutely.
Well, thank you everyone for your attendance. I think we are done if there is no any more questions.
Yeah, someone asked if we can share a paper on the Wittgen's technique. We have everything available, and we'll chat with Sebastian so he makes all that available for you guys.
Yeah. Thank you.
Thank you.
Thank you very much.